Hi, good morning, everyone. Welcome to our final Project Echo session for addressing barriers to healthcare and cancer prevention for adults with intellectual and developmental disabilities. We're so excited to have everyone on the line with us today in our Zoom room. My name is Michelle Jansen, and I'm the Community Outreach Coordinator with Rutgers Cancer Institute of New Jersey. And as the state's only NCI designated comprehensive cancer center, our goal is to always prevent cancer before it starts. In New Jersey, cancer is the second leading cause of death. 1 in 2 men and 1 in 3 women within our state will develop cancer at some point in their lives. We know that those with an intellectual or a developmental disability experience a greater number of health disparities that can then lead to a reduced rate of preventative screenings and a higher number of late-stage cancer diagnoses. Before we introduce our moderators and presenters for this session, we would just like to share a few tidbits of information about our Project Echo session today. We encourage everyone to have their cameras turned on if possible, just to encourage the flow of dialogue and the exchange of information as we go on our journey throughout the session. And we also just like to remind everyone to be sure that you're muted when not speaking, just to minimize any background noise. But of course, please unmute yourself for any comments or questions that you have. We also encourage everyone to use the chat box to enter any comments, and questions if you're not comfortable unmuting yourself. So the first part of our Project Echo session is going to involve an evidence-based presentation that's then going to lead us into an open conversation about best practices and developing solutions for common challenges that we may face in our practice and provision of services to individuals with special needs. Everyone in our room today is an expert in their own right and through their own unique set of skills and experiences. Our goal is really to bring all of these combined skill sets and experiences into one place where we can discover new approaches, build a set of evidence-based practices, as well as to share resources and connections to enhance the care that we provide in our respective disciplines and professions. We'll also be sharing a box folder with everyone within the next week or two that will have all of our recorded sessions for the past 8 weeks, as well as the resource guides that will accompany each of the sessions. So it's my pleasure now to introduce Laura O'Reilly Stanzales, who is the current Executive Director of the North Jersey Health Collaborative, who's going to help guide our discussion today and really get the conversation flowing. So welcome, Laura.
Thank you, Michelle. Welcome, everybody. It's really great to see some regular faces who have been coming and some new people. Thank you so much. We opened this wonderful session with amazing presenters who brought lots of information to us to help stimulate us to spread the word and act on being better advocates for adults with intellectual and developmental disabilities. We kicked off the series with Bev Roberts from ARC of New Jersey, who's on the call today. And we are capping the series with Dr. Deborah Spitalnik. I will introduce her momentarily. First, I'd like to say hello and introduce the North Jersey Health Collaborative's president, Sherry Cognetti. Sherry, will you say hello?
I'll unmute before I do that. Just as president of the collaborative, I value the strength of partnerships and working together to help with the health of our communities. And with this ECHO series, working with intellectual and developmental disabilities. So I welcome you all to this final session. I think it's been a great experience for all of these, and we look forward to seeing what Deborah has to say this morning. Thank you.
Thanks, Sherry. So now, without further ado, I would love to share Deborah Spitalnik's bio with you. Deborah M. Spitalnik, PhD, is a professor of pediatrics and adjunct associate professor of family medicine and community health at Rutgers Robert Wood Johnson Medical School. She is the founding executive director of the Boggs Center on Developmental Disabilities. Dr. Spitalnik chairs the New Jersey Medical Assistance Advisory Council and is a member of the New Jersey Advisory Council on Traumatic Brain Injury. She is a former member and past chair of the President's Committee for People with Intellectual Disabilities She has served as chair of the National Council on Quality and Leadership and president of the Association of University Centers on Disabilities. Dr. Spitalnik has promoted the health and well-being of individuals with disabilities through her research by developing innovative models for integrating adults with chronic disabilities into managed health care, and the development of curricula and educational materials for professionals and consumers. Dr. Spitalnik educates a wide range of constituencies and disciplines, including people with disabilities and their families, medical students, resident physicians, direct support professionals, and social workers. Welcome, Dr. Spitalnik, and thank you for being here with us today.
Well, good morning, and thank you. I really appreciate this opportunity. It's good to see some old friends and some new colleagues. And this is, I guess, a slightly different kind of presentation on healthcare policy and people with developmental disabilities. We all need to be advocates, and certainly seeing Beverly, advocate extraordinaire, on the phone. And what I'm going to try to do today, and for many people it'll be a review, is talk about really this larger service and policy context that really determines life for people with developmental disabilities and has great implications for access to healthcare. So very quickly, next slide. The Boggs Center is a lifespan program. It's part of the Robert Wood Johnson Medical School Department of Pediatrics, but we serve adults and children and their families and their supporters. We have 2 federal designations, both as a University Center for Excellence and Leadership Education and Neurodevelopmental Disabilities, which emphasizes autism as well as other disabilities, and particularly health disparities. We do a lot of work with state agencies. Next slide, please. We have a variety of functions, training of students, community training, technical assistance, and some of our experience that I'll draw on today comes from our technical assistance in terms of policy. Next slide, please. The role of the University Center is really envisioned early on by President Kennedy panel is to be a bridge between the university and the community. And certainly ECHO is a wonderful example of that. So I have a major theme, next slide, which is that health and disability policy, and therefore the health of people and well-being of people, is shaped or determined by larger social forces, as well as larger disability considerations. Next slide, just in passing, and certainly COVID has reminded us of that, and also the need for advocacy, that there have been a variety of policies that were developed out of necessity because of the pandemic, but that people with developmental and other disabilities may have special needs. They may need to have been accompanied by someone at the hospital who can help them communicate. They may need information in different ways. So next slide, just as a quick review, which I know that my predecessors' presentations have touched on, that people with developmental disabilities are medically, socially, and economically disadvantaged. Historically, people have been segregated. People often have multiple conditions, limitations in communication, which have implications for healthcare. Complex health and disability conditions are embedded in complex service systems, may have multiple caregivers, rely on public insurance, which is one of the things that I'm going to emphasize, have a need for care coordination. And as we're all acutely aware of, there's a lack of training of healthcare providers about the needs of people with developmental disabilities. And that's one of the main things that the Boggs Center is committed to. So very quickly, I want to raise about why advocacy is important. And in next slide, how did we get from here, next slide, to here? How did we get, next slide, from here to here? How did we get to, next slide, a paradigm where we've shifted from residential services to systems supporting people? And what, next slide, and what I would maintain is that we got there by advocacy, by families, people with disabilities, by supporters, by understanding policy, and that's our niche for today, and educating and partnering with policymakers. And we still have a long way to go. So I'm going to reach way back to the founding of the Social Security Act, the signing of the Social Security Act in 1935, because that has really provided both the platform for services and for our advocacy. And although Social Security was started in 35 just for income, it became, in 1965, it really became the basis for healthcare and eventually long-term services, with, in 1965, with the introduction of Medicaid and Medicare. Next slide. Medicaid is a joint federal and state program, pays for health services for low-income families with dependent children, senior citizens, and people with disabilities, as well as some people who are quote unquote medically needy because their expenses are high. And one of the things in the world of developmental disabilities is that there is, in some ways, from a policy and funding perspective, a blurring between what's health and what are other kinds of services. That doesn't imply that disability is an illness, but rather the ways that we support people are blended together. And next slide, Medicaid is a federal and state program. It's a partnership. Some things are determined by the federal government. And then what Medicaid looks like depends on where you live. And in New Jersey, as complicated as it is, we have a robust Medicaid program. Next slide. Medicaid is a public health insurance program, and it has resilience and flexibility that no other health insurance provides. And we've seen that during the pandemic, where Medicaid has put in place a variety of emergency provisions, has involved itself with the delivery of meals to many beneficiaries. And it's important in terms of disabilities in how we've been able to make Medicaid more responsive to people with disabilities. Next slide, please. Some of the things that distinguish Medicaid from any other health insurance that any of us might have through our employer is that there are protections and due process for individuals. And also, and this is really the advocacy message, that Medicaid federally requires stakeholder input. Beverly and I serve on the New Jersey Medical Assistance Advisory Committee. Anytime there's a program change, it federal government requires public comment, such as the renewal of the waiver. The other thing about Medicaid is that it has a public health perspective, that it looks at well-being of groups of people, and it also supports, next slide, acute care and long-term care. So in New Jersey, Medicaid is New Jersey Family Care, part of the Department of Human Services, Division of Medical Assistance, and also includes the Federal Child Health Insurance Program. Next slide. Medicaid does two things for people with disabilities, provides two types of services, acute care and long-term care services, that which we think of as the Division of Developmental Disability Service. Next slide. Through acute care for people with disabilities and other beneficiaries, or through a managed care model. And here's a list of them. What I want to call attention to, next slide, in terms of the lifespan, is that for adults with developmental disabilities, They are in a special category of Medicaid, but all children who are Medicaid beneficiaries, children from 0 to age 21, are treated as children, children first. And the way that disability is either uncovered or addressed is through a federal mandate of early periodic screening, diagnosis, and treatment. And this is a mandate that is much broader than anything that private insurance pays. And it is through this EPSDT mandate, next slide, that Medicaid now covers services for children up to age 21 who have an autism spectrum diagnosis. And these services are covered through are funded by Medicaid and implemented through the Medicaid managed care organizations. The Children's System of Care also provides services, but that's separate from the EPSDT. So I think it's important to remember that there's this entitlement for children and that these services have come about through advocacy by autism groups, first a benefit in private insurance, advocating for Medicaid, and the decision federally through the Centers for Medicare and Medicaid Services to implement these services for children that are now part of what's called the Medicaid state plan. Let's move on to the things that are more adult specific. Next slide. So in terms of long-term services, next slide, what are called long-term care in Medicaid, long-term services and support, are what we know in New Jersey as services to people with developmental disabilities. Those services provided through the Division of Developmental Disabilities. So if you're an adult with a developmental disability who's a Medicaid beneficiary, you may be getting your health care through managed care organization, but your community supports through DDD. It's also true for older adults. And there are people who are referred to as dual eligible, who have Medicaid and Medicare. Next slide. There's a category of Medicaid, unlike children, which are grouped as children, of called age blind disabled. It's a category of Medicaid. It's people who are SSI recipients, people who are clients of DDD. Next slide, please. So the idea of long-term services and supports in Medicaid originally began as facility-based care, nursing facilities, and began to be expanded to what we now know as ICFDD, the funding that goes to developmental centers. But in 1978, Medicaid shifted from only providing funding for services in segregated facilities to community services, home and community-based services. And the way that that came about was through a process called waivers. And waivers are extremely important. Next slide, please, because there is an institutional bias about the way Medicaid funded services. In 1970, when there was the Developmental Disabilities Act, it was assumed that services, community services for people with disabilities were going to be funded by the Developmental Disabilities Act, with all the poetry and the vision of self-determination, participation in community and daily life, inclusion, integration, and contribution. Instead, funding was lodged in Medicaid, which is a health insurance program. And so one of the challenges that we as advocates face is to make sure that services are really delivered in a community-based model. And I just want to share with you the human aspect of waivers, which we often think of as large documents. Next slide. So when Katie Beckett, the little girl you see here, was born. She had a series of significant health conditions and disabilities that required significant care that was being provided only in a hospital. She lived in Iowa. Her mother, Julie Beckett, who you see here, wanted to take her home, but Medicaid would only fund services in the hospital and at a much higher rate. And through a variety of advocacy by her mother with local officials, Congress, and eventually President Ronald Reagan, next slide, an individual waiver was granted to allow Julie Beckett to come home, Katie Beckett, excuse me, and receive her services. And that was the first waiver of the requirement for institutional care. Next slide. And to her, until her death in her mid-30s, she was a writer, went to community college online before it was as fashionable as it is now. She lived at home. And it was from that individual advocacy that became Medicaid policy. Next slide. And so we now know that Medicaid and waivers drive services through the Division of Developmental Disabilities. So DDD, as I think Beverly pointed out in her session, requires Medicaid eligibility to receive DD services. And the entire New Jersey Medicaid program, next slide, is part of the comprehensive Medicaid waiver. And this is a waiver that puts together all the Medicaid program in New Jersey. And it is in the process of being reviewed right now. New Jersey's had 2 5-year waivers and is in the process of applying for its next 5-year comprehensive waiver. So there's been a process of presentations, stakeholder input, written comment. New Jersey Family Care is reviewing the comments, making changes, and will submit the waiver to Centers for Medicare and Medicaid Services. They will come back to the larger community. There'll be chance for input, and this process will go back and forth until we have a new waiver. I want to, next slide, emphasize the direction in Medicaid for home and community-based services. It's a policy direction. In the American Rescue Plan this past March, in response to COVID, it was recognized that services to people with developmental disabilities needed to be enhanced. There was a COVID, and so there was money in the rescue plan for enhanced wages for direct support professionals and other provisions. There was a COVID Home and Community-Based Services Relief Act that and what the American Rescue Plan did was it enhanced the amount of money that a state gets its federal participation rate in Medicaid. And that was a result of a lot of advocacy at the federal level, with the understanding that the needs of people with developmental disabilities, which may have been significant before COVID, may have been even more so. In the COVID HCBS Relief Act, New Jersey and other states got additional rates of reimbursement from Medicaid to be used for a few years, to be implemented for a year, and then the additional monies that came from that to be put in place. Both that happening at a policy level, but how that was determined in New Jersey was a result of advocacy. And the pending Build Back Better Jobs Act is also includes more resources for home and community-based services. So what I want to really turn to now is, and I can pause if there's any questions or comments. I know this is out of most of our comfort zone as clinicians, as direct providers. Next slide, please. But what I want to turn to and reiterate is the larger social forces that are at play that determine downstream or within our own lives what happens on behalf of, to, and for people with disabilities. And that's really an iterative process between what goes on in Washington. We have a picture of the Capitol. We have a picture of the New Jersey State House. Today is election day, so I'll advocate, if you haven't already, vote. But what happens to people with disabilities is really determined often way beyond disability. I don't see any questions in the chat. So I'm going to keep going unless I get a nod from Laura or Michelle not to. And what I want to turn to is the Patient Protection and next slide, and Affordable Care Act. And this is a picture of the Affordable Care Act, often first labeled pejoratively as Obamacare, and then ownership of the term by President Obama and his administration, which is healthcare reform signed into place in 2010. Next slide. And for people with disabilities, the anti-discrimination provisions in this act are central. The coverage for pre-existing conditions, that you can't be excluded from insurance because of a pre-existing condition. If you change jobs prior to this and you have new insurance, either you or your family member could be excluded from coverage. That this addresses acute care and long-term care, long-term services, and within this is a presumption for community. The Affordable Care Act also eliminated annual and lifetime caps, which are kind of an invisible restriction, which was prior to this, insurance companies could apply an annual cap that you could only have a certain amount of coverage for your expenses in a particular year. So if you were a child with very significant disabilities, maybe you had cerebral palsy, needed a lot of surgeries, physical therapy, durable medical equipment, you could reach your lifetime, you could reach your annual cap before the year was over. And that was the genesis in New Jersey for the Catastrophic Illness in Children Relief Fund to address the annual cap. Similarly, lifetime caps. There was $1 million cap on insurance company. And while that seems like a lot of money, if you were a child that was born 2 to 3 months prematurely, you had a heart defect, you spent 3 to 6 months in the neonatal intensive care, you may have come out with $750,000 in healthcare costs. So you were pretty close to your lifetime cap for insurance. This is often invisible to the people we serve, and people only become aware of it when they've hit that. So the Affordable Care Act eliminated that. And for our purposes for disability, Medicaid was embedded in the Affordable Care Act. So next slide. So again, as my grandmother would say, I'm beating my tea kettle, that it's larger social forces that, as well as disability considerations, the evidence base, and what we know as practitioners, that inform disability considerations. And again, COVID really raised that. Next slide for us. One of the things that we know happened during COVID is that the number of people who lost their jobs, lost their employer coverage, wound up needing to be on Medicaid for health insurance. So I want to turn to some of these larger social forces next slide, and describe them. And I want to put a disclaimer or a caveat or a clarification is that I'm not talking about politics here. I'm talking about policy, but very frequently, different views of policy tend to be more likely lodged in different political parties and different political viewpoints. And that it's up to us as advocates to understand the policies and what's important for the people in our family, for ourselves, and the people we work for. So there are different views of the role of government in people's lives. Whether social programs support people who may be disadvantaged in some way or have additional needs for support, such as older adults or people with disabilities, or does that make people more dependent and less likely to function independently? And that's something for us each to consider. There are differing views of the role of government and the nature of the economy. We know that we're in a period of where we have a large due to the tax cuts of 2017, and that part of the debate now about the Build Back Better Jobs Act and the budget reconciliation are whether that would increase the deficit and whether that is a reason to not pass certain social programs or whether there are other ways of addressing that. We also know that elections make a difference, and we're hearing, despite the fact that Congress was elected a little less than a year ago, 11 and a half months, people are very focused on the midterm elections, meaning 2022, when the entire House of Representatives will be elected, and a third of the Senate. We had a presidential election which changed the course of healthcare policy. And we know that many of these issues where there is not unanimity across the culture wind up as court cases. I should mention, going back to the Affordable Care Act, that the Affordable Care Act was passed on strict party lines. Democrats voted for it and passed it. No Republicans voted for it. Since it was passed in 2010, when control of Congress went from Democrat to Republican back to Democrat, there have been 67 attempts at repeal and replace the Affordable Care Act, none of which succeeded. But it's important to realize that even though we are all beneficiaries of this, particularly the people we serve, this is not set in stone. And there are pieces of that that have been changed, one of which is the Medicaid expansion, which covers more single adults, many people with substance abuse disorder. New Jersey, when that became optional as a result of a Supreme Court decision, New Jersey opted in, despite that our governor was not a Democrat, because it made economic sense for our states. That's not true all over. And what's available to people with disabilities depends on where you live. So all these factors are at play, influencing what happens on behalf of the people we work for. And I think it would be fair to say, next slide, that our political, social, and policy climate is highly divisive, is highly charged. There are very explicitly different views of what's important, whether we're looking at mask and vaccination mandates, as well as larger issues. Next slide. So what happens in Washington both in terms of legislation that's pending and certainly in terms of the next election and what that might bode is very significant for people with disabilities, because it's not only what the composition of Congress is, but how the federal administration is populated. Our issues have always been bipartisan, or nonpartisan, but that has changed greatly as partisanship has become more inflamed. And so I want to raise the issue of what are the threats, next slide, to people with disabilities if there are major changes in policy. And first and foremost, protection for pre-existing conditions, that under the Affordable Care Act has been the only fiscally, insurance, and policy way that pre-existing conditions have been protected. There have been different kinds of approaches at the state level, things that are called risk pools, but none of them have ever really have addressed pre-existing conditions, whether it's cancer, Down syndrome, cerebral palsy, or that you were treated for a neck whiplash or a bad back, and you can be labeled as someone with a pre-existing condition. I talked about caps on expenditures earlier, but it's changes in Medicaid that I'm going to focus on, as well as ongoing court cases related to the Affordable Care Act and how Congress approaches the federal deficit, whether the debt ceiling will be lifted or whether it will imply cuts in programs. And I want to talk about specifically, next slide, about what are threats to Medicaid. One would be how much money the federal government spends on Medicaid, because there is a partnership between the federal government and the state. The state pays for a Medicaid service, and the federal government reimburses the state depending on the poverty level of the state. So New Jersey, as a relatively affluent state, has gotten 50 cents back on every Medicaid dollar spending. A lot of the innovation in Medicaid, the American Recovery Act in 2009, the COVID relief, has upped the amount of money that the federal government has provided. But what the pool of money is makes a difference. The other questions, the other threats could be who gets Medicaid, who is part of, excuse me, the population, the structure of Medicaid, how waivers are utilized either to strengthen the Medicaid program or weaken the program, and how is Medicaid a safety net program? What does that mean? Is it so bare bones that people don't get dental care, which has implications for heart health and overall well-being? Next slide, please. So I had thought that we had put some of these issues to bed, and I'm old enough to know that often things come around again. And I think we need to be conscious of what these proposals might be. The idea of block granting was a proposal that's happened historically, but was in the last federal administration. And the idea of a block grant is that the state gets a lump sum of money, which is usually less than the total federal spending. And the theory behind the less money is allegedly that because the money is coming in a block, there's less reporting, less administrative burden, and therefore costs would be less. But one of the main fallacies, in my view, of a block grant is that it's based on past years' spending. So if hypothetically we were block granted Medicaid and it was based on 2018 or 2019 money, and COVID hit in 2020, both the number of people who'd be eligible for Medicaid and our healthcare costs would be much higher. So being able to look at past performance doesn't predict future need. If fewer children are immunized, which is what we've seen during COVID, and more children contract measles, develop measles encephalitis, totally preventable, we might have a larger cohort of children with disabilities, just as we had in the early 70s when rubella immunizations were cut and there were children born with congenital rubella system. But the theory about a block grant is the state decides how to spend the money, and the idea that the state knows best. So there are fewer requirements or protections, but once you can see, this could easily lead to competition between advocacy for older adults, advocacy for people with disabilities. Next slide. The other ways that Medicaid could be threatened, in addition to block grants, are per capita caps, which is the federal government puts a limit on the amount it spends per person and says, this is all we spend on people a year. Similarly, annual caps and lifetime caps. Next slide, please. To me, the apotheosis, the epitome of things that happen away from disability that affect us is the pretty little known understanding that the 2017 tax bill that lowered the corporate tax rate, that changed coverage for state deductions, also repealed the required mandate for healthcare from the Affordable Care Act. So we don't think of the tax bill as a healthcare bill, but in effect it was. It changed the way you can deduct medical expenses, which made it harder for many families with complex conditions. And also by changing, and this is really far away from disability, the way that you can deduct state and local taxes that you pay. Also may have changed the resources available to families who have been demonstrated to have higher costs, out-of-pocket costs for healthcare and other services for people with disabilities. So I'm coming to sort of the end. I want to mention some continuing points for advocacy, next slide, that I would call threats. Whether parts of the Affordable Care Act continue to be challenged in local courts and make their way up to the Supreme Court, whether all of those changes produce instability in insurance markets. Even though I've emphasized Medicaid, we know that many people with disabilities, certainly under Affordable Care Act, can stay on their parents' insurance to 26, or if they're insured beyond that, there are ways of blending and braiding private insurance as first payers with Medicaid as the last payer. Also to be aware of, as there are electoral changes that can produce policy shifts. So not only legislation, but for example, the ways that Medicaid was enforced in the last administration through the Centers for Medicare and Medicaid Services, CMS, started to impose work requirements on certain groups of Medicaid beneficiaries, which we know is part of a vicious cycle. If you're not well, it's harder to work. If you're not working and you can't get your Medicaid because you're not working, your health could be in a downward spiral and certainly not preparing you for employment. Also, the changes in the Affordable Care Act changed the way that New Jersey provided for uninsured people, which was through charity care, which was limited in that it only provided care in hospitals. But with the advent of the Affordable Care Act, that provision went away. That state funding went away because we are now embedded in this federal state partnership. So last slide second penultimate slide, which is a listing of resources, is that one of the most important things we can do for our family members, our patients, our clients, the people we support, is to stay informed. And so this is a series of resources. And even though these slides are not going to be available in the box, I'm going to make sure that this slide is included along with this presentation. But I also want to close my presentation as we open it to question with the encouragement, next slide, that I drawn from Maya Angelou. I did then what I knew how to do. Now that I know better, I do better. And I really thank Laura and Michelle and Sherry for organizing this whole ECHO series to help us all know how to do better. So with that, I'd be happy to entertain comments, questions. And again, thank you so much for welcoming me into this process. So Laura asked an interesting question. Do we anticipate more MDs and providers providing primary care services to adults? We know that the provision of primary care, of people becoming primary care providers, is intrinsically tied to the structure of medical education, which is exceedingly expensive. Many people graduate from medical school with large burdens of debt, which are a real disincentive to becoming primary care providers, because primary care providers are reimbursed at a lower level, both in private insurance, public insurance, than procedures which, specialties which have a lot of procedures. There are things that I'm hopeful about in terms of that, in terms of the reorganization of care into affordable care organizations, the organization of value-based payment for keeping people well, rather than paying for people for procedures, I think promotes primary care providers. One I'll highlight two activities of the Boggs Center, one of which is that, or some of which are related to the medical students at Robert Wood Johnson, which is that there's a course in patient-centered medicine for the first and second year, and that always includes people with disabilities as presenters. We're moving towards simulated patients, so people are learning that in their career. Every third year medical student at Robert Wood Johnson goes through a seminar on family-centered care and developmental disabilities, where in addition to didactic instruction, they visit the homes now unfortunately remotely, hopefully soon in person, where the families are the educators of that. I think that's promising. Every family, through a program we established at Family Medicine at Monument Square, family medicine residents provide care to patients with developmental disabilities for 2.5 years of their 3-year residency, which is made possible by having a care coordination unit. And going back to some of the healthcare challenges, one of the main challenges that we have in providing healthcare, and particularly primary care, is the lack of care coordination, care management, case management, to make it possible to support healthcare providers and also help patients, families, and community providers thread their way through the healthcare system. There are larger national advocacy efforts around this, including trying to include questions about disability as part of the national medical exams, because we know that if there's content that's required on the exam, it drives curriculum. The other thing that I'm hopeful, and I am sort of ridiculously always optimistic, which is that in the emphasis on equity, diversity, and inclusion, a lot of which is being heightened by racial justice, that people with disability are included, and disability is seen as a form of diversity, and as well as intersection between race, disability, culture, and language. So unmute. And Mary,
Another question for you, Dr. Spitalnik. I know Bev Roberts had mentioned, in addition to the large expense to become a primary care provider with the medical training, that there's also a problem with new doctors that are willing to accept New Jersey Family Care and Medicaid. Have you seen that as well in your practice, and making these connections within the communities for those that you serve?
I think that, and certainly I think Beverly is extraordinary at helping make connections. Having trained family medicine residents for 30 years, what we found, and we just completed a follow-up study, was that when people have training and support of care coordination, they're more likely to see people in their practice when they graduate from residency. One of the significant problems we have is that when somebody is identified as having both the expertise about developmental disabilities and the sensitivity and the openness to seeing patients with developmental disabilities, people often get flooded with patients. And particularly if people are in private practice, people struggle with the payer mix of the number of Medicaid patients, the number of private insurance patients. This is significantly a problem with dental care, also in terms of the specialized expertise. And I'll go back to the idea of Medicaid as a public health program and reference what's called the Medicaid Contract as really an instrument of public health, which is in private insurance, disability isn't considered. There might be short-term funding for physical therapy. If I break my ankle and I cast or boot comes off, I get 8 sessions of physical therapy, I'm quote unquote restored to function, but there's not necessarily the understanding of habilitation, of ongoing needs that people have. And so within the Medicaid contract, which is an agreement between New Jersey Medicaid and managed care organizations, there are options for innovating, for developing specialized services, not necessarily specialized clinic. We're very committed to integrated care through family medicine at Monument Square, but there are some islands of excellence, notably Morristown Developmental Disabilities Center, but there is the opportunity for innovation. Where we are sorely lacking services, and there's the need for advocacy, is for mental health, psychiatric, psychological counseling care for people with intellectual and developmental disabilities and co-occurring mental health disorders. So much of the intervention for our population is considered related to quote unquote behavior and doesn't address the underlying conditions. And there are challenges in diagnosis of particularly people with communication limitations, people with intellectual disabilities, autism spectrum disorder that may have not only depression and anxiety disorders, but bipolar disorder and other significant mental health conditions. So that's really a plea both for training. There's resources that New Jersey budget, state budget is committed for psychiatric training, and we've got to advocate that the needs, the mental health needs of people with developmental disabilities are part of mainstream so-called behavioral health, different than what we mean by behavior in our field, but they're part of psychiatric training, they're part of psychiatric delivery. And as there's a movement to the integration of behavioral health and physical health, that has to include people with disabilities. So we're advocating for inclusion, both in terms of access, education, and the provision of care. I'm conscious of the time. I keep looking under my
Dr.
screen.
Spitalnik, we are at 9:29, but I think we have a really important question here, which would be a great way to cap this off so that we all can go out there and be advocates.
Good.
Mary Ellen Zung, who is a holistic health coach who is working on educating about the need for screenings for individuals with disabilities, is asking, how are advocacy organizations funded?
Okay, it depends on the advocacy organization. So the federal government funds University Centers for Excellence, the Boggs Center, and while we have a largely educational program role, we consider ourselves advocates based on evidence. Disability Rights New Jersey and the New Jersey Council on Disability. The ARC, where Beverly is, Family Resource Network, which includes Autism Family Services, Advancing Opportunities, which used to be United Cerebral Palsy. They're funded on the basis of fundraising, donations, and often contracts with the state. So it's a mix. We don't have any organizations in New Jersey that are solely advocacy organizations. Pennsylvania does, and there are challenges in both being a provider and an advocacy organization. I would also advocate on behalf of advocacy that so-called generic advocacy organizations, the American Civil Liberties Union, the League of Women Voters, any of these community organizations include the voices and the needs of people with disabilities and their families. But it is challenging. And the biggest unfunded but strongest advocacy comes from people with disabilities and family members themselves. And families are providing at least 2/3 of the care uncompensated that people with disability get. So we need to look towards families and people with disabilities, as well as strengthen and provide care and support in ways that strengthen the voices of the people we serve. So I appreciate that question
Thank you.
and this opportunity.
It's wonderful. So I would like to say on behalf of the North Jersey Health Collaborative that we will continue to promote inclusion of individuals with disabilities and special needs in community health improvement planning processes and in all the work that we do. It has been a wonderful 8 weeks, again, launched with Beverly Roberts from the ARC and our grand finale with Dr. Deborah Spitalnik. Thank you everybody for being a part of this. And please note that you will be getting links to the Rutgers Dropbox. Michelle Jansen will be sending that out. We will also be housing these recordings and any slides that have been contributed to the North Jersey Health Collaborative website. I would like to ask our president, Sherry Cognetti, to say some closing words before we end this session.
Hi, I just want to thank you all. I think this has just been such an educational seminar, these last 8 sessions, to hear from so many different people on this very, very important topic. I couldn't agree with Laura, that Deborah, your finale was awesome and very educational and learning. But again, the next steps, where do we go from here? That's what's going on in my mind, is where do we take this further? We certainly have educated a lot of people with this ECHO series on this topic, and my head goes to next steps. So we'll brainstorm on that. I'm sure all of us will as we move forward. It has been such an opportunity to work with the Rutgers Cancer Institute of New Jersey. It's been a great partner for the North Jersey Health Collaborative, and look forward to our continued work together on all of us in our next steps. Thank you.
And special thanks, Michelle Jansen, for hosting. Thank you, everybody. Have a
Thank
great
you.
day. Be well.
Bye, everyone.
Thanks so
Bye-bye.
much.
Thank you. Thank you, Dr. Spitalnik.